Thank you, Pam, and thank you for having all of us come across the river. We're all from Methodist Main Hospital, so we're excited to be down here at Jennie Edmundson. Our presentation is going to be on acute rehabilitation, determining the appropriate patients, the patient's journey through an acute rehab facility, and Pam already gave us all of our instructors, so thank you for starting me off there. Oh, I'm switching slides. There we go. The acute rehab centers that you have in Omaha, Nebraska, available to you to refer your patients to include the following three: Nebraska Methodist Hospital. Our acute rehabilitation unit is on the 4th floor inside the main hospital. Emmanuel Rehabilitation Institute, similarly within their hospital over at Emmanuel, and Madonna Rehabilitation Hospital Omaha, which is out west. All of the acute rehabilitation centers in Omaha have been certified through this stroke specialty certification through CARF. So they're all on the same level of care, same expectations of care through CARF. These images were taken from the American Heart Association website, their recommendations for discharge planning. These pamphlets, flyers, educational tours, educational guides go out to families and patients to help them decide what's the next level after you've had a stroke, when you're during a hospital stay and you're trying to determine where is the best level of care. The American Heart Association and American Stroke Association provide this guide within their website and to their families. You'll see there in the first column, which is what we're going to mainly focus on. My slide back there is so far away, it's like teeny tiny. So I'm going to look down a lot, I'm sorry you guys. The inpatient rehabilitation facility, acute rehab, those words are used interchangeably. So same thing there, and you kind of follow me through that first column. So the purpose of the program, medical services there, you see I put a little asterisk there. The requirement is 3 times a week, visits by a physiatrist. Oftentimes that's daily, especially in those 2 facilities we talked about that are housed within the hospital themselves. Oftentimes you can see that daily. The requirement is for 3 times a week. Nursing services, really similar to an acute care hospital, 24/7. Nurses are within the floor with us doing the rehabilitation part of that interdisciplinary team. The types of patients' needs, the patients who are coming to rehab facilities are able to tolerate 3 hours of therapy a day. That can be spread out over a 7-day course if an extended schedule is needed. So if that patient is not quite to 3 hours of therapy a day, we can spread that out from 5 days a week over 7 days a week to make it a little bit more tolerable. So we certainly work with patients and family members for those patients who aren't quite at that intensive level of care to help them get all of those hours within their week. The American Heart Association and the American Stroke Association recommend inpatient rehab facilities if the patient can tolerate that intensive level of care. It is their recommendation that this is the best place for our stroke survivors to go right after that hospital stay. This is the guide continued. Purpose of the program, rehabilitation services. You see all of us here in blue and Kayla, our nurse, in gray. Part of this interdisciplinary team, you'll have all of us working together collaboratively. The type of facility, this is traditional outpatient rehabilitation day program and home health care are the rest of those slides. So some more acute rehab admission criteria. When our physiatrists are accepting patients to rehab, they're sort of going through this checklist to see, is the patient going to be appropriate, will they be successful, and will we be able to progress them through our plan of care, you know, as it's outlined upon admission. So some of the things to look at are medical stability, including that completed workup on the acute care side, blood pressure management, and stable BP with activity. A good rule of thumb there would be less than 160 to 180 systolic. So we just want to see good blood pressure management. We want to make sure reoccurring strokes aren't happening once they transition out of that acute care phase. Multidisciplinary needs. So sometimes patients will just have a physical therapy need or a speech therapy need or an occupational therapy need. Identifying needs within all 3 of those services are necessary to justify an acute rehab stay. At least 2 disciplines out of the 3 are required to get that 3 hours of therapy a day, or again spread out over that extended therapy schedule. Good rehab potential expected over a reasonable period of time. Right now, the average length of stay in our region for stroke patients, someone who has incurred a stroke, come to acute care and then transition to rehab, is about a 2 to 3 week stay within the rehab unit. So able to make good progress in that 2 to 3 weeks is a requirement for admission to acute rehab. Prior level of function, reasonably high. Now that doesn't necessarily mean that it needs to have been high ambulatory or mobility-wise. They could have been in a wheelchair prior, but they were able to care for themselves, complete some ADLs, have good rehab potential to return to that prior level of function. If they don't have that high level of function prior to having incurred the stroke, there would be an additional need, such as a caregiver training. Okay, this is something new that the caregiver is dealing with. The patient prior was having care for, say, MS, but now they've had a stroke and they have loss of one side of their body. It's a whole new challenge, and if there was that need for caregiver training and the prior level of function was high for caregiver and patient together, that could also justify their need to come to acute rehab. A long-term disposition plan, ideally to the community. We love to get these patients through acute rehab back to their homes, so that ability to return to their homes, that interest in returning to their homes, both from patient and from family member, is ideal. And then other things such as need for home evaluations to ensure safety can be beneficial. This is sort of a flow sheet. You can kind of read through the flow sheet later on your own. Some things to pull from this is that acute care, so while they're in their hospital stay right after they've had the stroke, input from occupational therapy, which is myself, physical therapy, Travis, and speech language pathology, which is Jackie, is crucial during that stay. They're going to be able to provide you that functional need that you will need to justify to the physiatrist. This patient is really appropriate to come to a acute rehab facility. With that, same goes the well-written notes from your therapist, helping. I don't see any therapists in the room, potentially. Oh, couple. Hello, good. Well-written notes by our therapist. That's really crucial for us, and having those notes reflect the home. As we know, a lot of times in acute care hospital stay, the ADLs that we're able to do, the mobility that we're able to complete, the talking to other family members, speech language pathology can sometimes be limited within a hospital room. Really trying to identify with the patient, with the family member, what that care and what that home setup looks like so that you can simulate that. So, for example, the patient may be able to go to and from the bathroom within their hospital room, standby assist, no problem. We see standby assist, we say head on home, okay? Little do we know that bathroom is actually located on the upper level of their home, and they have to climb 14 steps every time they have to urinate throughout the day. That's necessary to know, because that in itself can help justify your patient coming to an acute rehab facility. Okay, that just really changes their ADL routine when we know that information. Same thing, like, they may be able to communicate, they may be able to order their own meals in the hospital room, so you're thinking, cognition is pretty good, but they share with you that they actually do all their financial management, all their own medication management. They've just had a new stroke. We're going to add 3 medications. They're at risk for diabetes and diabetes education. We heard Nicole talk about those things. That cognition that's required for home may be way different than what we're expecting of them in the hospital. So just knowing your home, asking your patient, asking your family and caregivers what that setup's like, and then trying to simulate that as much as possible within the hospital. For Travis's role, taking the patients out of the room so that you can get the whole flight of stairs if that's what's happening at home is necessary for those acute care rehab notes. And then they'll benefit from that direct MD oversight. I think that's really important. A lot of times these patients who have acquired a stroke are medically complex patients. They're at risk for a lot of decline in health if not addressed right now, right after they've had that stroke. Sometimes when they leave the hospital setting too early, they leave that MD oversight too quickly, then they can have worsening of those symptoms at home, misunderstanding of the new medications they have, not really getting into that diet, exercise, diabetic management that we want them to. So having that MD oversight for that 2 to 3 weeks longer can sometimes be really beneficial for your patients.
All right, so I'm Kayla. I'm one of the nurse coordinators on the rehab floor. So now we're going to take a look at our case scenario. So this is Jane, and Jane is a 56-year-old female who was out shopping, and she all of a sudden experienced some slurred speech, some right-sided arm weakness. So as a good nurse as she is, she decided to come into the emergency room, and she had some rapid workup done, and she also received some TPA. So when Jane came in, her NIH stroke scale was an 8 out of 32, and then 24 hours after receiving the TPA, she scored a 3 out of 32. So with this stroke scale, the lower you score, the better. So after receiving the TPA, her signs and symptoms got better. So while she was also in the emergency room, she had an MRI done that showed that she had an acute left anterior cerebral artery stroke, which affected the left parietal and occipital lobes, which ultimately affected her right side. So while Jane was in the emergency room, she was also seen by acute care PT, OT, and speech, and it was determined that she would benefit from acute rehab upon discharge from the hospital. So listed on this slide are the deficits that Jane actually was experiencing, and then listed below PT, OT, and speech are the deficits that those therapies will specifically address. So with this, it's important to remember that most of these deficits can relate to one another, which can affect each therapy as well. For example, with speech, she will be working on her impaired cognition, which can ultimately help with her impaired sensation, which OT will be helping with, which can ultimately help with or address her impaired gait. So all of these therapies kind of also relate to one another in a way. So it's just kind of important to remember that while Jane is on the rehab floor. So what can Jane expect on acute rehab? So she will be receiving daily rounds by the rehab doctor, and she will also have her own multidisciplinary team, which includes the nurse, the rehab doctor, OT, PT, speech, and also a social worker and the rehab care coordinator. So all of these people are keeping an eye on Jane's case. And they also meet daily in a team huddle just to kind of go over any changes either medically or physically that are related to therapy, and they are addressed in the morning so that they can kind of address it during the day during therapy. She will also have some stroke education, which she will get through a stroke education binder. So these binders are very patient specific, so they will address Jane's actual diagnosis, her medical history, her personal medications, and then throughout her stay, all of the people on her team will add education to this binder, and then when she is discharged home, this binder is something that she can take home to kind of help educate her throughout her journey after being discharged. She will also have her 3 hours of therapy a day, 5 days a week, or stretched out throughout the 7 days a week for a total of 15 hours a week. And then if needed, she will have a consult for the dietitian and also diabetic education as well. So what does the RN assessment how does it really differ between rehab and then also on a different floor? So when a patient is admitted onto the rehab floor, we do the usual admission history and also the head-to-toe assessment, and then also the skin check with another nurse to assess the skin integrity. And then we also establish the expectations, and we also introduce the stroke binder, like I just previously talked about. So when a patient is admitted, we will then orientate them to acute rehab. So we will go over the schedule, which consists of the 3 hours of therapy a day, and how it is stretched out throughout the day, and it's not all at once. We just kind of give them a heads up of what to expect and answer any kind of questions that they may have at this time about therapy. And then also the RN cares. So not only will we be giving the patient their medications, doing their assessment, and addressing any kind of medical care or concerns, but we also will be keeping a close eye on their bladder and bowel management, and also their intake and output management. So with the bladder and bowel program, a lot of the patients that come in to rehab are stroke patients, and one thing that they kind of lose sensation of is the ability to go to the bathroom. So we keep a very close eye on the patient's output, and also we have time voids scheduled during the day to help with bladder training and any kind of bladder maintenance. We also have the bowel program, which is sometimes used on patients who have had a spinal cord injury and who are experiencing decreased trunk and lower extremity sensation. So this program includes having a scheduled suppository to help promote bowel maintenance throughout their stay. And then with the intake and output management, we have the hydration and the free water protocol. So the hydration protocol is a specific fluid intake goal that depends on the patient's daily calorie needs, and also this number is established by the dietitian, and it can be found under the nutrition assessment tab under results review on Cerner. With the free water protocol, it is an ordered mouthwash that can be given every hour before the patient can drink thin water. So it's usually used on patients, especially on stroke patients, who are on a thick consistency fluids, so, and are trialing thin fluids. So we give the mouthwash, wait a half hour, the patient can then drink water, and if the patient were to aspirate for any reason, it would just kind of help prevent infection, but also it helps trial thin fluids, which can help with the patient's, help prevent dehydration and overall the patient's intake. So a lot of people ask me, well, what's really the difference between rehab nursing and nursing on any other floor? So with rehab nursing, a lot of the patients that we care for as rehab nurses are experiencing a lot of physical changes and are usually at a very low and depressing time in their life. So some of these patients aren't able to eat, talk, walk, and because of that, and because of what has happened to them, being able to care for these patients at not just a medical level, but also at a mental and spiritual level as well, for weeks to months at a time, really helps build that trusting relationship and that strong, solid rapport with the patient and the patient's family. So a lot of the cares that we provide with the patient are also intertwined with therapy as well. So things that they are working with therapy and some specific techniques we really try to apply with their nursing cares as well. Okay. And then this is Mary, who is with Therapeutic Recreation.
Good morning. I'm the recreation therapist up at Methodist Rehab. My name is Mary Belford, and I've been there for probably about 25 years. I'm here to talk to you about what we use for our assessments and evaluations. We collaborate with the other therapies and the nursing on the floor to do a lot of different things, a variety of things. One of the assessment tools we use are the brief interview for mental status, and we do that, it's called the BIMS, when the patient first comes on the floor in the initial 3 days. We need to do that assessment, and it basically looks, I always say to the patient, it gives us a snapshot of their mental status when they first come here. So it's a baseline for memory and orientation. And then the next tool we use is our assessment for leisure interests. We look at things that patients enjoy at home. It's really about quality of life. What are the things that are important to them, like you were talking about before, Nicole? And then we also look at their deficits. And we put those two things together to establish a few goals for them while they're on rehab. And we look at activities that are important to them and that they like to do, and what we can work on, which are some of the deficits, the same things that PT and OT might work on. It might be cognitive or physical. We try to adapt the activities as appropriate, or choose activities that would challenge them and help them with their with things they need to improve on. We also provide activities for the evenings and the weekends. It's been a little different with COVID, but right now we're able to do anything from music to, if they're doing projects or having things in the room to do with their family, those kind of things. Also, we help them determine what would be some options for them when they go home, so that they can continue to do some things they enjoy, and how they would modify those things. We are also, one of our other tools is a depression screen. And with our stroke patients, we determined to use the geriatric depression screen no matter what their age is, because it's simple to understand and administer, and it's pretty effective. So we get a good baseline again for their mood. I always say to establish their mood and help them with that. We also, as a whole team, do ongoing assessments of mood and coping ability, and that's all really, all the therapies and nursing are involved in that. And we try to help them along the way as needed. I always say that if you're not feeling good emotionally, it takes longer to get better physically, so those things go hand in hand. And then the very last tool we use is, we call the My Story, and that is a tool we use. Therapeutic recreation helps this patient fill out this poster, and it's basically information about them, about what's important to them, who their family members are they're close to. It might be, a lot of them love to put down their grandchildren and things like that, but also their likes and dislikes, movies, TV shows, music, if they have any pets. We also talk about their religious preferences on it. And it is really helpful for continuity of care, because what we do after we fill it out is put it up on their board in their room, and staff can come in at a glance and get an idea of who these people are, because a lot of times communicating isn't really easy to do, which leads us to why we help them fill it out sometimes. Sometimes patients can do it on their own, which is great, and then sometimes family members have to help them fill it out, or fill it out for them if they are having communication problems. So those are the 4 tools that we use to do the assessment when we get a patient when they first come on our floor. And now, yes?
Are they allowed to have visitors? With COVID this last year, I'm sure that was very different with who could come. Just having a family present for your rehab is really important.
It's very important. And initially, you're right, we did not allow visitors up there. And as a result, our department, recreation therapy, we came up on Sundays. And sometimes one of the things we did was we helped do, or nursing, or the aides helped to do Zoom calls with people too, family members. But oh wow, that was a really rough time when we had no family up. As soon as family came up.
Like the depression screening, do you feel like scores were a lot higher this last year?
Initially, yes. Or even after we did the depression during treatment, it was very difficult to maintain a positive attitude in their moods and all of that. Yeah, that's a good question. But yeah, no, we really did see that a lot. So does anyone have any questions for me? Anyone else? Thank you.
So moving right along. So I'm occupational therapy representation here. We followed Jane through her story just because we thought it'd be nice for you to picture someone in your head, someone who's had a stroke. Some of these things we're talking about, evaluation methods, treatment plans, would vary depending on the level of severity of the stroke. Not quite high enough. Thank you. Okay. So they'll vary depending on the level of severity. We wanted to give you as much access to a lot of OT, a lot of PT, and a lot of speech therapy as we could as we move through Jane's story here. So just take that with a grain of salt, and if anyone comes to mind other than that, feel free to ask us questions about how their assessment might look, speaking for all acute rehab units here in the area. So when they come to the floor, usually they're going to, we try to do it simultaneously, in the order that they will experience. They're going to develop that relationship with our nurse and their therapeutic recreation therapist. Their first therapy in that intensive therapy the very next day will likely occur with their occupational therapist. Occupational therapy is focused on ADLs, which is that morning routine. So that very next morning, they're going to get ready with their occupational therapist. The occupational therapist is going to be able to identify what deficits they have in dressing, toileting, bathing, grooming and hygiene, bed mobility, functional transfers, that kind of thing. So going through that morning routine, identifying those deficits so that we could build that treatment plan surrounding that. A lot of times, initially coming into the room, I'm Hannah, I'm going to be your occupational therapist. Our goals are they don't have occupation anymore. They're retired. So Jane isn't, so that's wonderful. She's like, I'd love to get back to work as a nurse. So of course we will help them get back to work. Before you can ever address that level of returning to your functional status, you have to be able to get ready in the morning. You have to be able to dress. You have to be able to bathe yourself in toilet. So those things typically come first. So that's that ADL assessment. Then moving into that instrumental activities of daily living. So meaningful occupations, returning to work, being able to prepare meals and do laundry and care for her family or care for her home. So those instrumental activities of daily living is that kind of next level that we'll move to after that ADLs or, within the ADL routine as well. Mobility-related activities of ADL and functional transfers. So there's a little bit of overlap, of course, between occupational and physical therapy. A lot of transfers occurring every single day throughout all therapies. So when I'm addressing functional transfers, it's often in and out of a bathtub, on and off a toilet, to and from their bed, things that relate to their ability to complete those ADLs and IADLs. So addressing their mobility, working with Travis and the other physical therapists to identify the best ways of transferring patients, and then helping the nurses to understand that as well, so that we can all be helping that patient improve their ability to transfer themselves more independently. Strength and range of motion assessment. So as we know, that left occipital parietal lobe, we're going to have right-sided weakness. Assessing what movement there is in that arm. In Jane's case, she had a flaccid, what we call no muscle activity in her right upper extremity. So testing that motion, trying to put her in positions where we could test just a little bit of movement, what we call trace movement in different planes against gravity, gravity eliminated, those kinds of things. And then assessing what are our strength and range of motion on the other side then. What is the strength and range of motion of our core to help with that pull of that right upper extremity? What is the strength and range of motion of the left side to get everything done throughout the day that we need to do in the meantime while we're working on that right? There's a piece of that neurovisual rehabilitation. She had an occipital lobe and parietal lobe injury, so she may be experiencing some neurovisual deficits as well. That falls within the occupational therapy scope to do a brief visual assessment, scanning, tracking, able to attend to persons or objects on the right side, identifying some initial deficits there, and then knowing the appropriate opportunity for a neurovisual optometry consultation if needed. So all of the area rehabs have access to a neurovisual specialist, a physiatrist in that way, who can develop a plan of care, and the occupational therapist can then carry that through, as well as the rest of the interdisciplinary team. Again, everybody's working on all of those deficits. So good communication. In Jane's case, she did have quite a bit of right visual attention, so forcing that right-sided use through all of her ADLs, IADLs is going to help her rehabilitate. Joint protection and assessment with a flaccid upper extremity, there's a high risk initially for that subluxation of the shoulder. The glenohumeral joint can pull down out of the shoulder joint. Educating on positioning, care of, attention to that right side. Oftentimes there's taping or electrical stimulation protocols that we put these patients on with those heavy arms. So addressing that joint protection and preventing any further problem there, as well as that wheelchair evaluation. At this point in her rehab, she is doing a lot of those ADLs from a wheelchair level, so positioning that arm for functional mobility within the wheelchair. After we've identified what we are putting within our plan of care, looked at all those deficits, figured out what Jane wants to do, what's important to her, then we're going to design an occupation-based intervention. So that's going to include one-handed ADL training. So hopefully she'll be able to dress and toilet herself before she gets a functional right upper extremity, because that may take a little longer. As we know, the stroke rehabilitation for limbs is, within the year, whereas we get that 2 to 3 weeks. So we really have to work on that one-handed ADL training. And patients are typically really successful at that. They surprise themselves sometimes what they're able to do with one arm. Sitting balance related to ADL safety. When you go to raise your left leg, your whole body wants to go over right. So working on that balance, as well as physical therapy, really owns the balance, but balance is related to ADLs in a lot of ways. So we're working on that sitting balance and safety. Improving tolerance and technique safety for functional transfers, which we talked about. Adaptive equipment recommendation and training. Any tools that would help them with self-feeding, self-dressing, those kinds of things, looking at those equipment that might be useful. Functional visual motor rehabilitation, developing that plan of care, trying to relate it to something that's occupation-based. Enjoying preparing a meal is something that Jane likes to do, so trying to relate that neurovisual assessment to gathering supplies in the kitchen, preparing meals, attending to that right side enough to keep it safe, working on that visual rehab. A huge part of that is that right upper extremity neuro re-education. I think you could dedicate 12 hours a day to neuro re-education of a stroke limb, and it would never be enough. So as much as possible throughout all disciplines, throughout the day, working on the gravity eliminated range of motion, weight bearing E-stim. These are all things, techniques for neuro rehab. So whatever it is that that patient is needing, depending on the level of their strength range of motion, we're going to incorporate that in that neuro rehab. Wheelchair level IADLs, progressing to standing IADLs, working with physical therapy collaboratively on the best device to be, completing those ADLs and IADLs with. And then, of course, family training. As Mary talked about, this is a tough time for them emotionally, doing things to incorporate their family, especially if there's children involved or grandchildren, trying to incorporate them into therapy and then train them how they can sit on Jane's right side and talk to her to help her with her neurovisual rehab all day long, or, positioning techniques for that joint protection. So incorporating the family as much as we can. Our goal is always to be occupation-based and doing what's meaningful and appropriate for each individual patient.
So I'm going to pick it up with Jane's physical therapy assessment. The running theme that I think we're getting here, and it's an accurate one, is that all of the disciplines are having some overlap in the assessments that they're doing and in the way that their interventions are going to address the impairments that we find. Now, in Jane's case, from a physical therapy standpoint, what I want to focus on is the strength, range of motion, balance, somatosensation and proprioception, and her assist level as it relates to her home environment. So I think most everybody in the room is probably familiar with manual muscle testing scores. When Jane first came in, that right hip, knee, and ankle were all scoring at a 3 or less. So she's barely beating gravity for most of these muscle groups. And in her ankle, dorsiflexors especially, she's not even beating gravity. Trace muscle activation was all we had at initial assessment. And so the strength deficit in her right arm, her right leg, and then, of course, the core. We think about the strength deficits in the extremities, but it's all right there in the core, too, is really contributing to her high fall risk, which was evidenced when we did the Berg balance assessment. For those of you unfamiliar with that, it's a very widely used balance assessment in the physical therapy world. And it's one of those balance assessments that's a little bit more labor intensive, but that score can then be taken to her home health care therapist, to her outpatient therapist. Jane was fortunate enough to go home from acute rehab, but if she hadn't been, her skilled nursing facility therapist would also have been familiar with that test. And based on her score, at eval, we would have had to have recommended a wheelchair for mobility because ambulation would not have been safe. In fact, I think she was a heavy moderate assistance for walking when she initially came in, with a second person there for safety. So not something that a person can functionally do at home. And that was unfortunate for Jane because she also lives in a tri-level home. So lots of stairs to get to the different levels of her house. And this might be something, when we were talking about patients that are appropriate for acute rehab, might be something that comes into consideration when we're determining is an acute rehab facility stay straight out of acute care the most appropriate thing for her. Now in Jane's case, she showed some significant recovery after the TPA. She has a husband at home who is able-bodied and ready to provide some assistance, so she has a very good shot of being able to go home from acute rehab. And as you'll see as we talk more about Jane, she had a wonderful recovery. By the time she went home, her husband was able to assist her up the stairs with, just keeping a hand on the belt for safety. But if she hadn't been, that's something that we're also working with the family on, assessing home modifications. Those stair glides are getting cheaper and cheaper, thank goodness. More and more people are using those if necessary. But those are some of the things that we're talking about when we're doing that initial assessment. Another thing that Jane really had going for her, at least in her lower extremity, was that her sensation was intact. Her somatosensation and proprioception were still present, which if those had not been, that would have greatly impacted our ability to get her back to a functional ambulation level, at least with minimal use of an assistive device. Most of our folks, when they've lost that sensation, then we're talking very much about what are some ways we can substitute and give that extra input for balance when they're standing and walking and completing their ADLs. So just talking a little bit about her assist level when she came in, moderate assist for gait. Stairs weren't even able to be safely attempted when she initially came in. And then at time of discharge, she was walking 400 feet with standby assist, and the same for stairs, just able to complete that. So the focus from a physical therapy standpoint, and again, we're working with our other disciplines to incorporate different things, but our focus would have been strengthening of that proximal musculature in her hip and in her core, which usually translates to improved strength more distally, and as that relates to balance. She got to the point where we could teach her not only to shift her weight if she needed to give that right lower extremity a little bit of a break, but then also with the functional return of a lot of that strength in her right lower extremity, those things sort of work together to build a stable foundation for her to stand on and for her to work from. Because her ankle dorsiflexion didn't improve as much as we would have liked, that's when, as the physical therapist, I'm looking at what are some adaptive equipment choices we can make to help her clear that foot. In her case, she did go home with an AFO, which is an ankle foot orthosis, which most of you I think are probably familiar with, at least in theory, just helping to prevent that foot drop when she's swinging her leg through. Those have come a long way, which is one of the advantages we have on acute rehab, is we have the time to kind of talk about different things that we can trial to find out what works best for a patient. I've had a lot of patients with hemiparesis that have kind of a knee buckle when they start to load that leg, and there are some AFOs now that will actually kind of push back on that tibia, on that shin bone, as you're loading the leg, which can help some of those people keep from buckling as well when they're loading their affected lower extremity. Another thing that was greatly affecting Jane's balance, as Hannah pointed out, was that flaccid right upper extremity. So if you think about flaccidity in an upper extremity, it almost becomes like an anchor, right? It's pulling you over when you're trying to stand and when you're trying to balance. And so, Hannah's working with her on neuromuscular reeducation to build the strength in that arm, taping to support the joint. PT and OT will work collaboratively to determine if an orthosis is also important or also appropriate for her to help to bring that arm up. And in a lot of patients' case, we have something that just sort of pulls that upper extremity and helps to support it even on their chest, so that it's not pulling them over as they walk, and that can be very beneficial to their balance as well. And then in Jane's case, because of the assist level that she needed and because of the place she started out at, we knew that family training was going to be very important. So we're doing family training as quickly as possible. It's wonderful now that we are able to have family members come back up to the hospital, and on the rehab facility, while we're still trying to minimize how much exposure family members are having to other patients, if we do need to bring family members down to the therapy gym for training, that's something we have available at Methodist campus. I can't speak to the policies of the other hospitals, but I imagine they're following suit or soon will be.
I'm Jackie, and in speech therapy. And so when a patient comes to, our rehabilitation floor, we evaluate their cognitive and language skills, which kind of go hand in hand. Very difficult to separate at times. And you'll see on the PowerPoint here the different areas that were looked at with Jane. I guess the thing that I wanted to mention was that in the general populace, about 15 to 20% of people have a mild cognitive impairment, and the risk of mild cognitive impairment are the same risk factors that, or many of the same risk factors that a patient has with stroke. So that, obesity, the lack of social interaction, I guess that one's more specific to mild cognitive impairment, but also, smoking, the high blood pressure, the diabetes that you referred to. And so we really want to make sure that the patient is ready to participate and have a good understanding of what their best learning style is, how can they maintain the information that is going to help them keep them safe when they return home and safe with their medications that nursing's educating them with. So are they able to communicate, use their language skills, and be understood as there's, and be able to understand what people are saying to them. So with Jane, she did test as having a severe cognitive impairment, and the assessment tool that I used with Jane does kind of break that out into her executive function skills as well as memory impairment, and she was deficit in both. And so I was originally, pretty concerned, as far as discharge planning, is Jane going to be able to go home, and how much assistance will she need there based on those cognitive needs. And then with her language skills, she was able to communicate and get her points across, but she did have a lot of hesitations and need for extra time. Her processing was slow, and she also needed some extra clarification of information simplified. So working again with the other therapists and nursing and family to help them understand kind of the best ways to communicate and to help Jane take in and learn. So in addition to more formal assessments, we do also do informal assessments. So just within the room, talking with nursing, is Jane using and remembering to use her call light, each time she needs to get up to use the restroom? Is she able to follow and understand her therapy schedule, which at our facility is posted on the whiteboard in her room. So is she needing repetitions? Is she able to, make a phone call, answer her phone? We see patients struggling with their own cell phones and, needing assistance and whatnot with that. So all of that's part of our assessment. And in addition to the kind of the cognitive linguistic component of assessment, we also look at the oral motor assessment and how that impacts both speech and swallowing. And so Jane did arrive to our unit on a soft and bite-sized diet with thin liquids. And she did have oral motor weakness and reduced range of motion, which then also resulted into difficulty with being understood. So her intelligibility was only about 75% in a one-on-one situation. And in the back of my mind, I'm thinking, gosh, Jane's a nurse and she's a triage nurse and she makes phone calls and, she is social and all of these things are impactful for her. And so when doing our assessment, many times that just sort of rolls right into treatment. And so Jane, was one of our more complex patients when it comes to speech and language because it was really treating all of the modalities, all of the areas of deficit were impacted. And so always in our minds as therapists and nursing and in a rehabilitation unit is, what is it that Jane needs to do in order to get home safely and to resume at the highest level of independence that she can as quickly as she can. And so on the screen here, you're just going to see some different modalities and ways that we worked with Jane. And I wanted to kind of show how all that gets pulled together in more of a functional, patient-focused way. So early on, a activity that was more functional was just having Jane order her own meals. And so this is a pretty complex task for somebody with Jane's impairments. And so, in collaboration with occupational therapy, looking at that vision, is Jane able to scan and read her hospital menu? Does she need a large print menu? Does she need a picture menu? What kind of modifications would be needed? Jane did not need those things. She was able to use her regular room menu, which was great. And then also working on memory. Back to the menu. When she's reading the menu, organization, those executive function skills, which showed to be poor during the assessment. I'm looking at, we're ordering lunch. Is she spending time, really reading through the breakfast part of the menu, or is she alerted, to herself, using her, cognitive skills to identify, I can just breeze past breakfast and now focus on things that would be more lunch relevant. So, and then, is Jane able to identify what it is that she wants to eat, and is she able to then remember what it is that she wants to eat in order to place a phone call? Will Jane need to use the menu to be able to refer back to in order to provide her some amount of memory assistance to recall? Not going to lie, I do that one myself when I'm ordering at a restaurant. I may flip open the menu and be like, I want these pork chops. So is Jane going to do that as well? So some people do that, but taking into consideration what Jane and her family are reporting Jane did before is kind of what we're targeting. Or is Jane going to need to be able to write down what it is that she wants? Again, a kind of a crossover here with occupational therapy, because now we know Jane doesn't have her right arm and Jane happened to be right-handed. So is Jane able to use her left hand to take notes and maybe her right hand to help stabilize the paper while she's taking notes, those type of things. So then Jane needs to make a phone call for the food service. So does she know where to locate her, the phone number for food service? It's, on the board, somebody who's not cognitive impaired is likely going to have read and notice and recognize that that's where the phone number is on the board. Will Jane need instruction for that? And then what does her working memory look like? Is she able to look at that phone number, pick up the room phone, and dial the phone number, keep in mind with her left hand now, from memory, or is she needing a constant look back? Does she need that number brought closer so that she can not have to shift her attention so far? So there's just so much cognitive skill involved in ordering a meal. Those were kind of some of the first pieces that we did. And you can see how that would overlay with Jane's triage nursing needs. She needs to be able to look at a screen and make a phone call. And I mean, there's obviously so much more complexity in that compared to what we were working on. But Jane progressed really nicely with that. As Jane continued to stay on the rehabilitation floor, we continued to work on all of these things. Her speech intelligibility was improving. Her swallowing skills improved. She did advance to a general diet and thin liquids, and was able to then have distractions put back in as far as having conversation while she's eating and that type of thing. But I was visiting with Jane and asking who she planned to talk with when she went home, who she was excited to kind of be interacting with given the COVID components, and she said she was going to talk with her kids and her husband. And I was like, well, Jane here has these flowers from friends. They've been, clearly supporting her with cards. And, and I said, well, what about like your neighbors or your friends and that kind of thing? And Jane said to me, I'm not ready yet. And so, my heart is just like, oh, I can't believe, she's not ready. Like, I feel like she's ready, but Jane wasn't ready. And so that really gave me a heightened sense of concern for Jane, and started providing intervention more outside of the room. And so what that entailed is we're still working on those cognitive skills. We're still working on that speech production and the speech hesitation. And we, consulted with physical therapy to find out, like, how far can Jane walk now? Does she have tolerance to make it all the way down to the gift shop walking with the speech therapist? So, making sure that we're both safe. And she did, so that was really great. And, was instructed by physical therapy. She might need some rest breaks. So Jane and I talk about this, and I put it in her cognitive court that if she feels tired, she needs to ask me for a rest break. And so we walk down to the gift shop. She's looking for certain items. We're again working on memory. What did we decide we were going to get? What are we going to get? We picked up some candy. Jane needed to, down there, cognitive task. How much money do we have? How many pieces of this candy can we buy? That type of thing. Bought the candy. Went back upstairs. On the way back up, Jane says, I think I could sit. And I was thinking Jane could sit too. So I was kind of like, we're going to walk real close to these chairs on the way back. And so we, I was pretty excited that Jane used that forward thinking, that those executive skills that were so impaired when we came in, to, recognize that. Back upstairs, we tuck away the candy, we put it in a drawer. The next day I walk in and I'm like, okay, so we have that candy, where is it? She's like, oh, we put it in that drawer. Great, okay, you're remembering. So we take that candy out, and now Jane is going to walk around the floor with me, and we're going to offer candy to the therapist, the nursing, the, people in 412. And so this is giving Jane lots of social interaction now. She's having to really put herself out there to be able to communicate with people that aren't her family and that aren't her safety net. And so it was actually really exciting to see her kind of like, sort of light up, and just, you could see that she was becoming more comfortable. And so those are ways we kind of pull it all together. Jane, when we started, when Jane said to me, I can't call my friend, despite encouragement and compassion and all of those things, she was just like, no. I had her develop a rating scale. I don't think I said this earlier. develop a rating scale, and from 1 to 10, and 10 was, I'm ready to call my friend. That was the goal. And when we started that week of therapy, where we started really getting out of the room, Jane identified herself as being a 6. So I was like, okay, we're only just a little bit over halfway there. But after those interventions and the opportunity to practice in a safe environment with support, Jane increased to a level 9 by discharge. And, she told me that she was a lot more confident and that she felt that in a very short amount of time she would be able to, reach out to her friend, that she was, going to start at the family, but she felt like she would get there very soon. So that felt like a win, I think, for everybody. So Jane, is experiencing the whole team, and that's those of us here in the room, in addition to, as Kayla had mentioned, the dietitian, the rehab professional, the social worker, the care coordinator, the family, the patient. Okay, so once a week on a rehabilitation unit, the patient will get together with the whole team. So we all, now are back in the room, and we talk about what progress we're making, what the ongoing barriers are for discharge. Is cognition improving so that she would be able to be left alone at all yet, or not? What are her physical needs still? What are her nursing needs? Those type of things. And then patient and family input, like, I can set up her medications for her, and I can call her to make sure she takes them, or, whatever that family input. So we have a little bit of conversation around that, determine kind of what our next plan is, and we're always talking about discharge. What could discharge look like? And that's an evolving discussion, because the amount of assistance at the beginning of the conversation is likely to look less at the end. It's just how much less is what we're sort of determining with the progress trajectory, which with Jane was very high, and likely related to that TPA that she was able to receive at the start of her stroke. Another thing that happens when a patient is on a rehabilitation unit is stroke education. And so, as Kayla said, they have this binder that the stroke education is put into, along with all of the other education specific to that patient. At our facility, one way that we provide stroke education is through a group called Stroke Chat. And so this group meets once a week, and it's a really fun group. I feel honored to be able to help lead it, and it's a chance where, I am able to provide information on, like, what is a stroke? I mean, that's how I start the group usually, and many times, that's one that patients, even if they've been educated, maybe aren't remembering. The repetition is necessary, but also gives the patients the opportunity to connect and realize, like, okay, other people are here that have had a stroke too. So it's sort of that beginning of that stroke support. Patients are able then to share their experience with stroke. What were the first things that they noticed? What were those signs and symptoms? And then we can kind of cross, like, look, Travis noticed that he was having trouble with balance, where Mary was having a hard time with her speech. And so that's different, across people. So kind of just a neat way for patients to experience that education. At that group, we also provide them information on stroke support groups. There's actually a really long list of stroke support groups available in the state of Nebraska. These are a few of them on this screen, and on the references page, there's additional there's a link that they can click on. Hannah put that on there for us. So, if you know people outside of the kind of the Omaha area that could benefit, you can look there to get them information. It's life-changing to have a stroke, and I can only imagine that if myself or my family member had a stroke, that I would want the support of other people that have had a stroke. So Travis is going to jump in now.
So I'm going to pick back up for discharge planning here. So when we're talking about preparing for discharge, there's a lot of things that we're going to be going through because, of course, the most important thing that we want for our patients that are going home is that they're going to be successful at home, right? Regardless of what level of care they're at, if they're going home from that level of the care, the last thing that any of us want is for our patients to go home and fail and have to come back to the hospital. So some of the ways we do that, community reentry is at the top of the list. This is something that's kind of taken a hit with COVID, but you know, we're getting there, we're getting close, and hopefully we'll be restarting that. But it's a way for us to take patients out into the real world and have them practice all of the skills that they've been learning with their therapy teams. In Jane's case, being a triage nurse, I mean, we can, you know, everybody in this room can imagine how hard that would be in terms of the cognitive processing that has to take place and just the multiple areas that you're going to have to be attending, the complexity of the information that you're getting when you're making decisions. While we can't replicate that exactly, you know, taking somebody to the grocery store where they're having to work on money management, following a list, item selection, walking through a busy store where, you know, there's a lot of visual stimulation, things coming up in Jane's case on her right side that she needs to use those compensatory strategies of turning further to the right to find everything and to make sure that she's not hitting any obstacles or people, all in an environment where she's going to have a little bit of a sense of heightened expectation and heightened stress because now we're getting back into the world. It's really good to be able to simulate those real world situations. For some of our retired patients, you know, it might be a little bit more leisurely. We had a patient a few years ago really wanted to return to golf, and so we took him back to the driving range and had him work on the balance aspects of, you know, being able to stand unassisted, hold the club, take it through the rotation movement. And so that community reentry group might be just a different combination of therapists. Oftentimes the recreational therapist is there, but if we're doing the store for money management, it might be speech therapy and or OT. If we're going to the golf course, it might be rec therapy and or PT, but just getting those groups together so that we can go out and practice these things is very beneficial to the patients. Home evaluations are pretty much a staple at acute rehab, all facilities, and what we're doing is then we're trying to take the patients back to their home to do a sort of dry run. You know, we've been working on all these skills. Let's put them to use in their home environment. Are they able to successfully navigate their stairs? Now, in Jane's case, she had a railing for her stairs, but would that railing be more beneficial on the other side? So if she's got right hemiparesis, she's going to be leading with her left leg when she goes up the stairs. Her railing happened to be on the left side, so that's good when she's going up the stairs, but now what happens when she has to go down the stairs? You know, now it's on her right side. So having a right-sided railing where she can turn, you know, use a different technique, turn sideways and sort of do a two-step up the stairs and then back down the stairs so that she always has something for her right hand was a suggestion and a recommendation we were able to make. You know, and it's things like that, things like removing trip hazards, rugs, cords, making bathroom modifications, grab bars, tub benches, and then having ideally the family there so that we're practicing all these things. Oftentimes we'll load up a lot of equipment and bring it with us so that we can practice in the home with the patient and know that if there's any surprises, we're finding out about them now. And then we can take all that information, go back to the hospital, and help to, that really, in my mind, helps us decide when our discharge date is going to be. Because we'll decide how many problems did we find, you know, do we need another week to get all of this addressed? Did she fly through it? No problem, and we can talk about discharge tomorrow or the next day, you know. But having that information is crucial. Equipment recommendations and acquisition of that equipment. So for our folks that are going home at a wheelchair level, you know, we're collaborating with CRT, complex rehab technology providers, here in Omaha or wherever area the patient is going to have access to them when they go home, and having them come in and actually assess the patient and get them fit for that wheelchair and determine what accessories on that wheelchair are most appropriate for the patient, and have that as quickly as we can so that they can practice with it before they go home. When it comes to other pieces of equipment, there's a lot of services in Omaha. At Methodist, we're fortunate enough to have an equipment loan program, which Hannah wonderfully set up for us. And, it's one of those things that if a patient can't afford to purchase that equipment on their own, what resources are available to them? Is there a foundation associated with the hospital that can help them cover that material? Is there a loan program that they can use to get that material? HELP is another program in Omaha that I'm sure many of you are familiar with, where you can go to rent and or purchase equipment at a reduced cost if you're needing that. And then there are other groups in the area, philanthropy groups, that will just sometimes help to patients to apply for grant money to get that equipment. So there's a lot of resources available to patients. We just need to know where they are and how to get these patients connected with them. Family caregiver training we already kind of touched on. That's hopefully taking place throughout their length of stay. If we've got a family member that's there and able to participate, and identifying what their role is going to be when the patient discharges. Going back to equipment, sorry I missed this. I feel like I focus too much on the physical side of things, but talking about things like maybe an electrolarynx, not for our stroke patients necessarily, but for our laryngectomy patients. I was really excited when I heard about blister packs. Have you guys all been introduced to blister packs yet? So some pharmacies now are putting people's pills, they're organizing them in rolls that almost look like toilet paper rolls. But as you unroll each pack, it tells you what the date and what the time is that you need to take these pills, so that they're not having to caddy them up. It's not appropriate for all patients, but it's just one of those things that, at an acute rehab facility, we get exposed to a lot of this stuff. And so it's great then to be able to say, hey, I think Jane would be perfect for that. Home exercise program development, is going to be individualistic to the patient, and it's going to include, our arm exercises, leg exercises, balance, walking program, physical activity, as Nikki had mentioned. The CDC has that recommendation of 30 minutes of moderately intense exercise on most days of the week. A lot of our patients are not going to go home being able to do that, but are they aware of the recommendation, and are we helping get them set up to work toward that goal? And a big thing that I'm finding I usually feel the need to educate a lot of my patients about is the moderate intensity level. A lot of them can go through exercises and never reach that level where they're breathing a little heavier, and that's really what they need to help decrease their risk for future stroke. Our social workers and our care coordinators are behind the scenes doing all kinds of work to help them get set up for home, making sure that they've got a 30-day supply of all those new medications when they go home, and that's been called into their pharmacy to set them up with appointments so that they're not going home and having to take that on themselves, because that can be a daunting task, and people can slip through the cracks, obviously, if that happens. So just making sure that they already know what the next steps are in terms of therapy, home health care, outpatient, whatever that might be, before they're going home. And then, of course, we give very detailed discharge instructions in addition to all the training, so that patients have that written reference that they can go back to and say, oh yeah, now I'm supposed to go up the stairs with my left leg first and do 2 feet on each step, and my husband's supposed to be behind me supporting me in case I lose my balance, sort of thing. So those are just a lot of the things that go into preparing them for discharge. So here's our references page.